on there?
Sorry, that was me.
No, that's okay. I'm just trying to, now what did I do? Now I've hit something that I don't know what I did. How do I get rid of this screen?
I
Okay.
only see your slides.
You can still see the slides or no?
Nope, I can see the slides.
Okay, well now I can't see it because I've expanded something by accident. Okay, I think I'm good. Oh my goodness. Okay. I guess we will get started. I can't see anybody who's in the room. So hello to everybody who's in the room. And hello to everybody online. This is our second last session. So thanks everybody for coming. I know Lindsay couldn't be here, but she wanted to attend, but says hello to everybody as well. Yeah, so this is a pretty big topic, and I will always start with the pre-session quiz, which is up there. You should be able to click that QR code. What's that? Or somebody not muted, which is fine. So yeah, if you haven't done so already, please complete the pre-session quiz. If you're chatting with any of your gal pals who attend these, let them know that this session is being recorded and we are going to send it out after, as we always do, which should be fairly quick since we don't have to wait for editing and all that stuff. And Maggie, thank you for doing an excellent job on these slides. You guys will notice that compared to the ones that I did last time, they are much better. This is what happens when I get them to Maggie in lots of time. So she can work her magic. All right. Today's big topic, sexual health, pelvic health, and intimacy, something I love talking about. I want to again just kind of, oops, turn my phone off here, make sure I don't get all kinds of distractions. Ding. Welcome everyone, and just say that this is a safe and supportive space where we can talk about all the stuff that we often don't talk about. You might kind of giggle, you might cringe a little bit, but I do promise you that you're not the only one wondering if what's going on with you is normal. The answer is most likely yes, and we're going to talk a lot about it today. So we want to understand what's going on down there, as some of us like to refer to it as. We want to explore practical evidence-based treatment options, and hopefully by the end of it, if you do have a partner and this is an issue, we can learn ways to talk about intimacy with our partners, and also our care providers. If we have something going on and we're not comfortable speaking to our doctors or nurse practitioners about it, hopefully this helps empower you to be able to speak about it. Know that you're not alone and you don't have to suffer in silence. And as always, to navigate this life transition with confidence. Any questions at all, let me know. Maggie, I can't see if anybody raises a hand or does anything, so feel free to interrupt me at any point in time if anyone has a question.
Will do.
Thank you, my moderator. All right. So, genitourinary syndrome of menopause is the most current and accurate term for basically any genital or urinary symptoms that are caused by the changes that occur throughout the menopausal transition. So you might hear your physician or somebody calling it vaginal atrophy. That is a component of it, but it is not the whole thing. It's actually a very pejorative and, minimizes us even more as women. So you feel free to correct your doctor and say, that's actually called the genitourinary syndrome of menopause now. Can you please, update your language? So what it is a collection of signs and symptoms that are associated with estrogen deficiency that can involve the vagina, the vulva, the bladder, and the urethra, which is why it's the genitourinary syndrome of menopause, because it impacts more than just the vagina. Historically, our misogynistic healthcare system wanted to reduce us to, the use of our vagina and our ovaries, but there have been lots of people along the way who've advocated for women's health, and this is where we're at now. So the symptoms must also be bothersome and not caused by an alternative diagnosis, which we'll go into a bit. It is chronic and progressive, and if you do have symptoms, they are unlikely to improve without treatment. So this isn't something that generally just gets better on its own because it's related to declining estrogen. It really does impact everything, and because we are not necessarily going to get that estrogen back unless we are on a treatment, that's why it's progressive and chronic. And like I said, the vulvovaginal atrophy or vaginal atrophy, as some doctors might call it, is a component of genitourinary syndrome of menopause. But that specifically describes the appearance of genital tissue. So it doesn't encompass everything else. And the presence of the atrophy is not indicative of symptoms. Some women never even know they have it. And so basically, as with everything, we want to look at our symptoms and is it bothering us? So that's what we will get into. Some common symptoms, which you may be a little surprised to hear. I know I was initially. So the most common is probably vaginal dryness, irritation, or burning. And that can lead to some other concerns as well. So most of the symptoms can creep in slowly. Many of us just assume it's aging or something we have to live with. Some of us have been told by our practitioners that it's just something we have to live with, which is not accurate at all. There are solutions, and we will talk about them today. So, so again, the vulvovaginal dryness, vaginal itching, burning, or irritation. We can have a change in our vaginal discharge, and we can have a change in vaginal odor due to the changes in our pH. So if all of a sudden you have a change in your vaginal odor, sometimes it's an unwanted change. That could be one of the reasons. So urinary wise, we can have pain with urination. We can have more frequent urination at night. We can have just urinary frequency or urgency, so having to go more often. Yeah. How many of us don't pass up a bathroom? We're on a long drive, right? Recurrent urinary tract infections as well, which is something that many of us might not realize. If we all of a sudden are starting to get recurrent urinary tract infections, it could be related to the declining estrogen, and sometimes just including a vaginal estrogen can help with those recurrent UTIs. Sexual symptoms as well for those of us who are sexually active or who this is important to. So we have decreased lubrication and arousal with sexual activity. We can have pain with insertion during sexual activity. We can have pain with sex just all around. We can have delayed or decreased orgasms. And we can also have postcoital bleeding, so bleeding after and with sex. So that is all often associated as well. So, and muscle weakness causing incontinence. Again, we'll talk a little bit about the pelvic floor, but we did have our awesome pelvic floor therapist come in and talk as well. So I'm not going to touch on that a lot. And so this is a kind of a busy slide, but it's like, what's going on down there? What's the pathophysiology of the genitourinary syndrome of menopause? So Maggie was awesome and found this graphic, but it shows you kind of the side by side what, I don't like that it says normal vaginal environment because it's all normal. I will say this is a premenopausal vaginal environment on the left-hand side and a menopausal vaginal environment on the right-hand side. Both are completely normal. One is the menopausal vaginal environment is not abnormal. It's completely normal. It just depends on whether it impacts you or not. So, our ovaries produce lots of estrogen pre-menopause. We have lots of glycogen-rich epithelium, which is just that part of the tissue. We have a nice thick epithelial lining. We have a good supply of blood. We have, generally speaking, good vaginal lubrication, lots of pink tissue, loss of elasticity, lots of collagen-rich tissue. We've talked about that before, how estrogen impacts our collagen, which is also part of our vaginal tissue as well. our pH, it regulates our pH, which is why we, advocated for years not to have women douching, because that douches do not interrupt our vaginal pH, and our vagina has its own microbiome as well, and it's self-cleaning. We do not need to douche. Um, and then the menopausal vaginal environment, again, we have that reduction of estrogen, and the other hormones, but primarily estrogen that we know of at this stage that impacts the vaginal tissue. So we start to lose the epithelial lining. We have a reduced blood supply, which they are doing more research on, that they think impacts a lot of things, including a decreased sexual orgasms and things like that as well, which is why like the producers or the makers of Viagra have tried so hard to find a little blue pill for women that increases blood flow, because that's what it does for men, but the studies show it just doesn't do the same thing. So they're going to keep trying to find a drug for it, but I don't know if they ever will. And we'll get into why soon. So again, so we're like decreased collagen, decreased tissue elasticity. The tissues become more pale in color. We now have reduced lubrication, so it's drier. And the vaginal canal is often narrowed and shortened. So all these things basically is the pathophysiology and why we get the symptoms of decreased estrogen. Some other causes. So here is a slide with a whole bunch of medical lingo on it. I basically I got a lot of these slides from the Menopause Society, and Maggie asked me to translate this one, but I'm not going to, because basically this is just telling you that there's a lot of different things that it could be, and I wanted to keep this on here just to highlight that, um, you know, our sources of social media and the people we follow might try to lead us to believe that everything is just menopause related, but as I talked about a lot in the beginning of these sessions, was just not everything is. We don't want to always jump on the hormone train and just assume that's what's happening and not get it checked out. Stay curious, get things checked out. If there's something abnormal going on that you've noticed, that you felt, just get it checked out. You can have all these different crazy medical diagnoses here that could be going on at the time. So that's the whole reason we left this slide in here. I'm not going to explain what each one is. If you have it, you know what it is. If you're going to get it, you will know what it is, because your doctor will explain it then. So how does genitourinary syndrome of menopause affect intimacy? And I think this is where a lot of the pharmacies and all the research regarding trying to find a medication to, increase women's libido or increase blood flow to our genitals is lacking, because they're missing the big picture. So intimacy for us, especially, it's not just physical, as I'm probably preaching to the choir here. We've talked about this a lot, but it's about, and it's not just about sex. It's about connecting with our partners, connecting with ourselves, first and foremost. And when things do feel off because there's something physical going on, it can throw off how we feel inside of our relationships and also about ourselves. And I just really want everybody to know that you're not alone in feeling this way. So it can cause us to avoid intimacy because of pain or fear of pain. It's a super taboo subject. We've been conditioned to, like I've talked about before, conditioned to feel like we're supposed to be hot and ready in 5 minutes, like Michelinas, right? And we're not. It takes a lot more than that to get our engines revving. So we can feel less confident and desirable. We have less pleasure or arousal, and we can worry about urinary leakage or discomfort. So there's lots of things that goes on that how just the physical parts of genitourinary syndrome of menopause can affect intimacy. Um, I'll get into the emotional side of things in a little bit, but that's kind of the yeah, I guess what I'm trying to say, that's the physical aspect of it and how it can impact our intimacy. So that said, actually, before I move on, does anybody have any questions about the pathophysiology of genitourinary syndrome of menopause? Is there anything that you're unsure about or want some clarification on? Again, I'm not a gynecologist. I'm a nurse.
Go ahead.
I'll do my,
The question,
yeah.
just on the last slide, that would be exterior, or is that possible to have it interior of the vagina? And
What's that?
the dermatitis or those sorts of skin conditions?
Yeah, absolutely. You can have it. The contact dermatitis, I would say, would be probably more external. But again, I'm not a gynecologist. But all of this can be internal, it can be external. There can be, yeah, things that happen at the urethra. So,
I ask because I know I've had trouble generally with eczema.
yeah.
Never did all my life, and so that just made me wonder, does that indicate something internal that maybe I don't even know about? So
Yeah, eczema is a strange one, and I wonder if it's hormonally related as well. I actually got and stress related. I got it kind of under my eyes this past year, and I had lots of stress. And I've never had eczema, so I think I don't know this for sure. This is just me talking out my ass right here, but I think there's a it's I would say it's related. I think hormonally stress this time of life, our estrogen is our juicy hormone, so everything just becomes drier. But yeah, that's a good question, and I don't know if internally if there's um some problems. I would definitely get it checked out. Some irritations and itching and things like that, especially if it's new for you. Like I would say anything that's new, go get it checked out for sure. Okay. Anything else? That's a great question. Thank you. I wish I was a gynecologist and had all the answers, but okay. So what happens to desire? Um, Sexual health can be important to our overall sense of self and well-being, whether we're partnered or not partnered, for those of us who are sexual. But it's super important to note that there is no standard to meet when it comes to sexual activity and desire, despite what we have been conditioned to believe as women. Some of us experience a significant decline in desire at midlife, and some have an increased interest. um, it's like I feel like they're 18 all over again. I have one of my girlfriends is like that. I'm like, holy cow, where did this come from? I kind of wish I had your increase in desire myself, and made me a bit jealous, but I didn't know that can happen. I kind of assumed that just everybody was a slow decline, but some people have an increased interest, and others notice no change at all. But only ourselves and or our partners can know whether our sex life meets our needs. But there's no one right way to experience desire during this phase of life. It's your sex life, and it's if it's different than it used to be, it's okay as well. The question isn't what's normal, it's more, does it work for me? Does it work for me and my partner? Is this something that we need to look at and talk about? So if you were to go to your doctor about sexual dysfunction, um, there's, I think in like, and I hate that it's classified under the DSM-4, but it's classified in the disorder of mental health. I don't know why it's a mental health thing, but anyway, there's 4 classifications. You can have 4 areas where sexual dysfunction can occur. So you can have an issue with sexual desire itself. You can have an issue with becoming aroused. You can have sexual dysfunction as related to orgasms and also sexual pain. So if you have sexual dysfunction and this is something that is bothersome to you and you go to your doctor about it, they may or should try to tease out kind of what the issues are, and they'll look at them under those 4 categories. So, do we have medical problems? Are there hormones? Does our partner have sexual problems as well? And often these problems will overlap. So, for example, someone who doesn't experience sexual desire may also experience difficulty with arousal or having an orgasm. These problems are more common than you think. Many women deal with more than one. But again, the good news, like we're going to talk about, is there are options. So I just don't want anybody to suffer in silence. So sexual desire, I'll just kind of describe what they are and how they're classified. So sexual desire is a reduced production of the reduced production of estrogen at menopause can cause hot flashes and night sweats, for example, is just one example. So not having a restful sleep might reduce an interest in sex. The declining in estrogen levels that can result in the vaginal symptoms that we talked about might make penetrative sex painful. So that all can impact our sexual desire as well. And just like the Venn diagram here, they all overlap. Our hormonal changes, they're only part of a complex set of factors that influence our sexual activity. Social changes, such as changing partners, whether we've just had a recent divorce or whether we're dating, our children leaving home. We might have the empty nest syndrome, which changes things. Maybe our children are coming back home when we weren't expecting it, which is changing things as well. Or maybe we're so incredibly busy caring for our young ones and our aging or ill parents. And all of these things can take place at the same time as our hormones changing, which can impact it. Our partner's sexual problems, again, these might also affect desire and factors such as changes in body image and self-esteem. And if our partner's not willing to talk about it, we may feel like it's us. We may put, as women often do, we blame ourselves for things. Maybe they don't desire us like they used to, and not realizing that maybe they're having their own insecurities about their own issues. And their sexual interest after menopause also depends on our past level of sexual interest. The studies show that as well. And often there might be some, our medical problems may result in low desire also. So some of the medications that we might be treated with, like antidepressants, things like that, can also interfere with our sexual function too. So sexual dysfunction and menopause, again, kind of overlapping here, but our sexual concerns frequently present during midlife because of hormonal and biopsychosocial factors like we talked about. So those biopsychosocial factors are everything from what's happening physically to what's going on in our environment and our stress, and psychologically how we're feeling as well. And when we're looking at how often it's reported and treated, sexual concerns in midlife remain underdiagnosed and undertreated. Again, it's a very taboo subject. Women don't want to talk about it. We've been conditioned to believe that we're supposed to stay youthful and wet and ready and all the things that we're told, which is absolutely not accurate at all. 40 to 50% of women report at least one sexual problem, but again, this is probably underreported. Low desire with or without distress has been reported by 48.5% of women between the ages of 45 to 64 years old. Sexual dysfunction is commonly associated with emotional issues, social functioning problems, and relationship conflict, and also non-specific medical conditions. So again, back to that kind of Venn diagram there, everything kind of overlaps and intersects there. Maggie. Oh, is there a question? Sorry, I'm hearing somebody. No, okay. I love this. Maggie found this. I can't tell if I need a nap, an orgasm, or 15 glasses of wine. I think I said, Maggie put that in there, and I said, I think it's all of the above at this phase. I need all of it. How about the well, maybe not 15 glasses of wine, but a glass of wine, an orgasm, then a nap. So beyond sexual desire, there are 3 other categories of sexual problems for women. We've got, again, like we talked about, difficulty with arousal. So that just means that some women may find themselves unable to develop or maintain genital arousal, difficulty with orgasm. So whether it's a new development or a lifelong concern, some women may struggle to experience an orgasm. And sexual pain, again, it can be caused by a number of factors. If it's caused by vaginal dryness due to decreased estrogen, lubricants and moisturizers can help maintain moisture and reduce friction. And then we'll get into also some of the other medical treatments as well, like vaginal estrogen therapy. So again, I think this is a bit of a repeat, but factors associated with sexual dysfunction. And I think it's important to repeat it because um, I think there's a lot of people online talking right now like, oh, testosterone is going to cure all your sexual problems. And we don't have enough evidence to support that. So sexual dysfunction itself is multifactorial. There's your physiological issues like we talked about, psychological and emotional, sociocultural influences. I was talking to our local pelvic floor physiotherapists, and I was asking her about something called vulvodynia. Vulvodynia. So basically, like when the vagina or the vulva are so tight that there's pain with penetration or penetration, their partners are unable to penetrate because of the pain. And I said, what is often the cause of that? And in her experience, it's she had mentioned working a lot with the Mennonite community. And so she said often religious background and our experience of, you're often taught that this is not okay, it's dirty, it's wrong your whole life until you go to get married. And then you're supposed to have this magical evening. But now you have these conflicting feelings of this is wrong, it's dirty, I'm not supposed to be doing this, and all the shame and the guilt that's been indoctrinated into us. And now, but all of a sudden you have a husband and the mighty magic penis is supposed to come along and make us feel better, and we're supposed to bow down to him. So it just, there's so many things that I truly believe when we are having these kinds of issues, it could be so much more than just a physiological, and we need to stop being blamed basically for that kind of stuff and get the help that we need. But physiologically speaking, we can have neurological problems, we can have heart disease, we can have cancer, the urogenital disorders like we talked about, different medications, fatigue itself, like how many of us are not just exhausted on a daily basis, our hormone loss and abnormalities, and chronic pain. So these are all the physiological things that can be associated with sexual dysfunction. When we're looking at the psychological and emotional side of things, if we have anxiety or stress, or too much stress, our self-image, which changes immensely during this time, depression, history of abuse and trauma, and alcohol and substance abuse, all of those things can impact our sexual functioning. Sociocultural influences, again, limited sex education because it was a taboo subject, conflict with religious, personal, or family values, and societal taboos, again, like we talked about. I think that's why I like talking about this, because I love talking about anything that's taboo. My mom used to say that I would say things just for shock value. But I think it's because I was just advocating, right? I didn't know it when I was younger. Maybe I said it for shock value, but now I just turn that kind of into advocating for women's health and for things that are taboo. And of course, our interpersonal relationships. That can be like we talked about, our partner's performance and technique, a lack of a partner, if we want one, relationship quality, conflict, and communication. We're going to get into that a little bit. And of course, logistics, a complete lack of privacy. Maybe you've got kids that have just moved home. Maybe you've moved your parents into your home. That lack of privacy can be a huge influence on our sexual dysfunction and sexual desire. Excuse me. Okay. So menopause symptoms and sexual desire. So again, our menopausal symptoms, overall, we're just not feeling like ourselves. Lower sex hormones can mean less desire and fewer orgasms. And on that note, again, there's testosterone is currently indicated in Canada for women for sexual desire disorder. But there's no blood test that can diagnose that. That's it. That's why I think it's more of like the psychological testing as well. So testosterone blood tests don't diagnose low sex drive in women, so they're not helpful for treatment decisions. So again, if you're going to a practitioner who's wanting to do blood tests to see what your testosterone is, to see if that's what's causing your low desire, and that's the only thing they do, I would inquire about further testing and further questioning and maybe someone who has a bit more experience in it. Because again, it's typically not the only reason. It could be low testosterone could absolutely be a cause of low desire, but it's not the only cause. So stay curious, be the scientist, right? Go out and get as much information as you can. And like we talked about, the lower estrogen can cause the changes, the physical changes in our vaginal, vulvar, and bladder tissues. So again, we can fix that. But menopause itself are like, again, hot flashes, night sweats, not sleeping at night. Chances are pretty good I'm not going to have the energy to do extracurricular activities. Trouble sleeping, if my partner knows not to put a hand on me at 3 o'clock in the morning, because he'll probably get an elbow to the face. My sleep is important. Don't try to do that at 3 o'clock in the morning. Again, that fatigue, that overarching, just absolutely bagged. Weight gain that can decrease or impact our self-esteem. We can have the mood swings and the irritability that can come along with some of our menopause symptoms, and all of that can lead to a decrease in sexual function. There's a few little tweaks. I've got a good friend of mine, and somebody that I've been doing a lot of menopause stuff with, Muskoka Mel, I think she calls herself. I call her my dildo peddler. She sells anything to do with sex and intimacy. So all kinds of toys and lingerie and, oh my gosh, creams, lotions, you name it, she's got it. But one of the things, we were doing a session, and one of the things she suggested to someone who says, they have their partner, they're postmenopausal, she's most postmenopausal, wanting to continue on with sex. But by the time they come to the end of the day, they're just completely bagged. They've made dinner, done everything else. So she was just like, well, have sex before dinner. She's just like, oh, we'll just change the schedule a bit. Like, let's set aside the intimacy time to before dinner, so that you're not just wanting to lay on the couch after a nice big meal. So those kinds of little tweaks to our schedule, I guess, with our partners and talking with our partners can have a big impact as well, if that's important to you. So like I said, it's probably not your hormones, despite what every social media influencer is trying to sell us on right now. So low desire is not likely just your hormones. If you're experiencing pain, you need to talk to a medical provider. There's been some incredible research by Dr. Lori Brado. She is a researcher out of BC somewhere. I can't remember if it's UBC, who she's written books. She does a ton of research on sexual desire, and especially as it pertains to women. But in all of her research, there's been no significant hormonal predictors of low desire in women. So, and through her research, she's found that hormones play actually a small role in sexual well-being. Emotional and psychological factors matter more. And anecdotally, we probably know this, I think, right? As women, we probably are very aware of what's impacting our desire. And so low desire doesn't mean you're broken. Sometimes it's about changing the context. And Dr. Brado talks a lot about this in her work. So beyond the hormones now, why our desire often drops? Stress. How many of us don't have a ridiculous amount of stress right now, especially being that what we call that sandwich generation, caring for aging parents, and maybe we're bringing, maybe we have young children of our own, or we're bringing, our adult children back into our lives, or now we're caring for grandchildren. Like, who knows? There's a million different things going on, it seems. Anxiety, this could present right now. That fatigue again, that chronic tiredness, just feeling disconnected, disconnected from our friends, disconnected from ourselves, disconnected from our partners. Past traumas can also rear their ugly heads right now. Changes in our relationship, maybe we're going through a divorce, of course. So all of these things can impact our desire. And our brain is truly our biggest sex organ. If our brain is on overdrive with kids, work, parents, never-ending to-do lists, our desire switch might not even turn on. But that doesn't make you broken. It makes you human, and that's okay. And there's a lot of research done, and a lot of the sex therapists will talk about responsive desire. I think I've talked about it previously, but especially for women, but even for men, I think the studies show it takes at least 14 minutes, 14 to 20 minutes for women to get our engines revved. So we got to switch off our brain to stop the to-do lists, feel connected again with our partner, be in that present moment. And so that's what they call responsive desire. So when, if sexual dysfunction is a concern, these are the questions that a sex therapist or somebody who knows what they're talking about should ask, when you get going, is it okay? And a lot of women will say that, yeah, I'm fine once I get going. I just don't want to start. But once you start, it's okay. And then you get going and everything's great and you have a great time, with your partner and hopefully have an orgasm. But that's responsive desire. It's completely normal. And that's what most of us, not all of us are hot and ready in 5 minutes. Some of us are, and that's fabulous. But some of us really need to take that time to get that engine revving. And that's where a good sex therapist can come in handy to help with those kinds of like tips and tricks and tools of the trade to get things revving, get the engine revving. So maintaining intimacy during menopause. I took this, I think, straight from the Menopause Society website for patient information, but we need to prioritize our connection. And again, when we're talking about intimacy, that doesn't have to be with a partner if you don't have or want or need one, but prioritize the connection with yourself. So connecting with yourself, connecting with your partner, become experimental and adapt to different changes. Using supportive tools, so lubricants, every woman should use a lubricant, in my opinion. That if you don't and things are dry, you get micro tears, and that's where you can get adhesions and things can, and it just doesn't feel good. You can use daily moisturizers if you do have problems with the muscles being too tight, like our pelvic floor physiotherapist had talked about. There's vaginal dilators, and there's also vaginal hormone therapy, which we'll get into here shortly. Emotional safety, super important. We need to feel emotionally and physically secure and safe in our relationships. Those things increase our intimacy. If we're not gonna, chances are pretty good our desire is gonna be pretty low. And again, self-compassion is at the base of this because that overarches everything. Be patient with yourself. We need to, make sure we're talking with ourselves, with our partners, getting the help we need if this is something that's impacting your life on your terms, not just your partner, yourself. So when we're talking about partners, of course, for those of us who have one or want one, so we, super important to be open and honest. And this is where that safety comes in. Do I feel safe and secure to talk to my partner about these things? If I don't, is this something that I need to reevaluate for my life? Or is this something that they're willing to go and speak to a professional about so we can work on it together? So being open and honest, encouraging patience and empathy, discussing solutions together, normalizing the conversation. It might be awkward at first. And of course, setting boundaries. That's always important. So these are the highlights of communicating with our partner, and effective communication and feeling safe and secure in our relationships. And some really helpful resources if, low desire is an issue for you right now. Better Sex Through Mindfulness is again by Dr. Lori Brotto. I would highly recommend as a resource, Dr. Brotto and also Emily Nagoski, who does the forward in this book, both excellent resources when it comes to evidence-based evidence-based information and evidence-based help when it comes to sex and desire. So those are fabulous resources. And you can, I listened to the Better Sex Through Mindfulness on Audible, so you can get it on audio as well. Yeah, it's such a great tool. All right. So, just looking at the time. So we've got treatment. Because like I said, we do not have to suffer in silence. There are treatments. So typically, if you went to your gynecologist or went to your doctor and you're talking about vaginal dryness being an issue, the first line of defense they'll talk about is, lubrication with penetrative sex, and then moisturizers. So they will talk about moisturizers. It's, just like a facial moisturizing routine. There's vaginal moisturizers out there. In Dr. Gunter's book, she's got two books. She's obviously got the Menopause Manifesto and then the Vagina Bible. She lists moisturizers that she has found, that she's researched and has found effective. So she's like, stay away from the flowery, smelly stuff. Like we're already, told that we don't smell right or we're supposed to smell like roses. I don't know. Anyway. But yeah, so for a good list, I would consult one of her books. She might have it on her blog as well, or even your gynecologist. Pelvic floor physiotherapy, again, is something that can be super helpful for some women, depending on what the issues are. Vaginal dilators and vibrators are good. So, oh wait, sorry, I'm just going to look at my notes here. So for the lubricants, sorry, short-term relief for pain of pain with penetration, and they're used before or with sexual activity. Your moisturizers improve the hydration of the vaginal mucosa, and they're used on a regular basis, regardless of sexual activity. So even if you're not sexual, it can just help with some of that itching and uncomfortableness, and is often what some doctors and gynecologists will first recommend. And usually every 2 to 5 days is needed. Pelvic floor physiotherapy is pelvic floor physiotherapy. We don't need to go over that. The vaginal dilators and vibrators. So the dilators mechanically stretch vaginal tissues and can help relax pelvic floor muscles. Yes, and your pelvic floor physiotherapist can also help with that. Regular vulvovaginal stimulation, which can include masturbation and partnered sex. So they used to say if you don't use it, you lose it. I don't love that. That's not actually accurate, but the regular stimulation, whether by masturbation or partnered sex, increases the blood flow to the area. So the more we can increase the blood flow to the area, the better. And some other considerations are your doctor could also prescribe you some topical lidocaine, so a freezing agent that a freezing cream that you would put on that can help before any dilation, like using dilators or vaginal penetration. You can get Botox injections, which help relax the muscles as well. There's vaginal laser therapy is something that's out there, but there's not a ton of great evidence to support it. And I think in the States, I don't know about here, but platelet-rich plasma injections. I don't know a lot about that. It was just on the list of things that are options that are available out there. So just highlighting there's lots of options. When we're looking at lubricants, so this is really individually based. So some people like water-based, some people like silicone-based, some people like oil-based. Lubricants can be used by both or all partners or applied to devices. So the water-based benefits, they're compatible with latex and silicone. There's less risk of a yeast infection. They're generally inexpensive. And some products may not decrease sperm motility. So, if pregnancy is a risk, then that's something you want to look at and talk to your doctor about. The drawbacks of it, they can dry out really quickly and they might contain glycerin or parabens. And the silicone-based benefits, generally compatible with latex, does not dry out as easily as the water-based ones. They can be a bit more expensive. So some of the drawbacks, they can be difficult to wash off. They can be incompatible with silicone and rubber, so some vibrators and dilators. And some products may increase the risk of yeast infections. And the oil-based ones, generally inexpensive. So we're looking at vegetable oil, olive oil, coconut oil, vitamin E oil, things like that. They can erode condoms though. So if condoms is something you need to use, that might not be a good option. And that again can increase colonization of candida, so yeast infections. So again, very, very, very personal. And try different ones, but just use the lube, I always say. My personal favorite, I'm going to endorse one right now, is something called Uber Lube, Uber. You can get it off of Amazon. You can, yeah, it's silicone based, but it also has vitamin E oil in it. It just feels really nice. Um, I've actually used it as kind of like a moisture. It's not really a moisturizer, but like externally as well, because it just kind of makes everything not so dry and sometimes irritated. So it's quite lovely. That's my own personal endorsement there. And no, I don't get any kickbacks from it. And actually, that's one that I learned about it long before I heard Dr. Jen Gunter talk about it, but she uses it in her office. She got the company to send her samples. So she uses, instead of using that muco jelly that the doctors use that I can't stand, she uses that in her office, and she says she's never had a complaint from it. But anyway, again, um, and just another option. So fractional laser, Maggie, I love this. This was the fractional laser was something that was put on the Menopause Society slides that I got a
Go
lot
to
of
the
this
next slide.
from.
You have to go to the next slide.
Yeah, I'm going to, but I wanted to read this because I love Austin Powers. It's been a family, movie that we've loved forever, but sharks with frickin' laser beams attached to their heads. And so any Austin Powers reference makes me smile. Um, so yes, so fractional laser, energy-based devices that may improve vaginal health. It causes micro trauma. They're not FDA approved. So again, I don't know a lot about it. If this is something that you've heard about and something that somebody's trying to sell you on, just do lots of research on it. That's all. Is basically what I'm going to say about that, because I really can't speak to it because I know nothing more about it. So vaginal and pelvic floor activity. So again, like I talked about, regular stimulation, solo or partnered, can help increase the blood flow to the tissues. Our natural secretions, when we have them, can help keep tissues healthy. So if we have severe genitourinary syndrome of menopause, might need a combination of everything. We might need some pelvic floor physio, plus vaginal dilators and medications. And pain with penetration often needs a full team approach. Looking at, again, our pelvic floor physios, sex therapists, maybe some CBT or hypnotherapy, and medication. So we want to think of our vaginal and vulvar tissues like any other muscle or skin. They need good circulation to stay healthy, regular stimulation, whether that's with a partner or solo. Yeah. Pelvic floor physio. So I'm not going to get into this a lot, like we said, but it can address pelvic floor dysfunction because of muscles that are too tight. I know that Carolyn and Brittany talked a lot about that. Sometimes we need to relax more. So if we're already squeezing so tight all the time and then we try to squeeze more, we just can't do that. Whoops, didn't mean to move that. They use an array of techniques. So manual therapy, where they're actually like going in through the vagina or the rectum and manually like massaging or stretching the tissues. They can use dilators as well. Like I said, it involves some internal and external work. The therapeutic course for that is typically 4 to 8 sessions that are an hour long, typically weekly, and with some home exercises. And there was a systematic review of a couple of randomized control trials and 27 observational case series, so a lot of studies that found that 59% to 80% of women noticed an improvement in their pelvic pain after pelvic floor physiotherapy. So very beneficial, the studies do show. So now we're getting into a little bit of the hormone therapies. This is just one of the pictures that I could find that just gives you a good visual representation. So you can have localized vulvovaginal estrogen therapy. So they can come in a cream, which is kind of the first one, which is typically Premarin. You can have the E-string, which is a vaginal ring, and I think it stays in, for about 3 months, and it just slowly releases some estrogen to the tissues. I think it's inserted, basically the applicator looks like a tampon. and that's how that's inserted. I think we can do it ourselves unless we want our doctor to do it, but it's not like an IUD where your doctor has to do it. We can insert the E-string on our own. I don't know if we do have the vaginal suppositories in Canada. We definitely have the vaginal tablets of estrogen as well. That's usually called Vagifem. Otherwise, this is where I kind of wish Lindsay was here for this part, because I don't know, I'm not a prescriber, I'm not a physician, but these are the things that are available from an estrogen hormone therapy perspective for localized. So our local vaginal estrogen therapy is effective for the treatment and management of moderate to severe genitourinary symptoms because of low estrogen. It's recommended where there's an inadequate response to non-prescription therapy. So again, if you've tried the moisturizers, you're doing the, the lubes, the everything else, and you're still having lots of symptoms, that's generally the next step. The local vaginal estrogen therapy is preferred over our systemic therapy because it has better efficacy, and there's also negligible systemic absorption, which I'll talk about in a bit. So generally speaking, if you're high risk because of you've had hormone responsive cancers or blood clots, local vaginal estrogen therapy is a consideration for those high risk individuals, whereas our systemic therapy may not be, but I'll show that in a second here. You can also get DHEA as well, and the SERM, the ospemifene, which is a oral medication, can also help. I'll go over that in a bit here. So other than vaginal estrogen therapy, like I said, we've got our DHEA inserts, the oral pill, which is the ospemifene, if I'm saying that right, and testosterone as well are other medication options that you talk about with your doctor. Again, I'm not a prescriber, so if you have specific questions about that, that's where I would speak to a specialist, either a gynecologist or your GP about it. So the estrogen therapy, just a brief chat on that. So we have our local hormones. This is what I'm talking about here. So local meaning that the estrogen is actually inserted into the vagina, so it's getting into just the local tissues. Typically a low dose. It comes in the cream, tablet, ring, and the insert. It works right where you put it. Minimal hormones in the bloodstream. So again, a safer option, or can be a safe option for women who've had hormonally responsive cancers and also women who are at risk of blood clots. It's used for dryness, pain, and leaking, and we don't need progesterone to protect our uterus if we are using vaginal estrogen. Whereas if we take the systemic hormones, so we're looking at our pills, our patches, our sprays, they go through the whole body. Those are to treat our hot flashes, moods, sleeps, bone health, all that kind of stuff. It can help with some symptoms. Again, it's going everywhere. But with that one as well, we also, if you have a uterus, we also need progesterone. So if you're just having vaginal symptoms, or those are your most bothersome symptoms, vaginal estrogen therapy is a great option for most and many women. So again, just a quick overview here, some risks of the risk of vaginal estrogen therapy in high-risk patients. So it's safe for women with non-hormone related cancers. So if you're somebody who's had bowel cancer, let's say, it is completely safe for somebody with a non-hormonal related cancer. And it can certainly be considered with estrogen sensitive cancers. Again, you need to talk to your team about it. There's lots of data now that's coming out to show the safety of it. But again, that's where it's like your risk versus benefit. What is your risk tolerance? If this is bothering you so much that you need and want treatment, you can advocate for yourself to give it a try for 3 months kind of thing. And again, if you are somebody who is at risk of blood clots, there's no increased risk of blood clots in lots of the studies when it comes to the local vaginal estrogen therapy. Yeah, I think I talked a lot about intimacy, so I don't need to talk too much more about it, but intimacy is, we need to prioritize our emotional connection with both ourselves and our partners if we have one. We need to be patient with ourselves, try new things, new positions, the timing of our sex, that kind of things. Use the tools that are available to us, lubes, dilators, vibrators. Don't put pressure on ourselves, and please don't let anybody else pressure you. Intimacy evolves. It's not always fireworks. Statistically speaking, I think I said about this, yeah, takes women 14 to 20 minutes to get out of our heads and get the engine revving. Maybe that's slow dancing in the kitchen, laughing, holding hands, or just a good conversation. It doesn't have to look the way it used to when we were young and, raring to go all the time if we were. Be clear with our partners about what we want and need. If it's not a safe environment to talk about these things, we may need to seriously consider our relationships. Just talk about it. Talk about it with girlfriends. Get the conversations going. You're definitely not alone. I hope if nothing else at the end of this, if you have something going on like this, you're just like, phew, wow, I'm not the only one. This is, and then you feel empowered to talk about it with friends, with your doctor, your care provider, and advocate for a gynecologist if you're not comfortable with your doctor. And I don't want to end on this note, but I'm, like I've talked about before, I come from a background of working as a sexual and domestic assault nurse. So I will always talk about our safety when it comes to domestic violence. So when intimacy isn't safe, if our relationship involves fear, control, or harm, please know that help is available. Please reach out to a trusted healthcare provider, counselor, or a hotline if it's safe for you to do so. The Assaulted Women's Helpline is there. And again, like I said, this presentation will be sent out, so everybody will have access to that. And there's a sexual and domestic assault treatment center at OSMH in Aurelia that is an excellent resource as well. And that is it. Every naked person I see turns me on. Nice addition, Maggie. Any questions? Maybe I'll stop sharing my screen now. Oh, wait, no, I'll wait because I'll keep that post-session quiz up.
I just wanted to say that after putting together these slides, my search history is very strange and I'm getting really weird targeted ads. Lube, a lot of lube.
I have no doubt. I see something in the chat, so I'm just going to open that up. And this sounds about right. If you can actually turn off the to-do list in your head. Yep. Ain't that the truth, Jackie? Yeah. Everybody got the chance to do the post-session quiz. No, I'm going to stop sharing now. There. Hi. I'm back.
Oh,
Anybody have any
I
questions?
have messed up one of the questions in the quiz. I am so sorry. I am going to go fix that right now.
Oh, okay.
Or I will fix it today and I will send out the quiz again. As always.
In the post-session email. Okay. So
Okay.
maybe we'll.
But please fill it out. I'm so sorry. That's all on my fault, but yeah.
Thanks for whoever caught that. Did you catch it, Maggie?
Yes. No, I didn't.
No. Awesome. Well, I don't see any questions. Is there anything in the room, Maggie?
Does anybody have any questions? Oh,
Thank you very much.
Oh, there we go. Fixing sleep will help with libido and ED and can be a symptom of sleep apnea. Man, absolutely, Catherine. Sleep impacts everything too. So Catherine in the chat says, in my sleep disturbed breathing studies, I found that sleeping will help with libido and ED, erectile dysfunction, and can be a symptom of sleep apnea in men. Absolutely. It all like the blood flow. Yeah, if I'm not sleeping, don't touch me. I don't want anybody to touch me if I haven't had any sleep.
oh, whoops.
Are we still recording?
Oh, it is.
Yeah, it is. But if we have questions that we don't want recorded, we can stop the recording.